Can the Ebola outbreak in the Democratic Republic of Congo be stopped? The head of the World Health Organization seems confident and says there is hope. But with an already volatile security situation in the region, what are the risks of the virus spreading? This is Inside Story. Hello and welcome to the program. I'm Folly Thibault. We are catching up. The words of the head of the World Health Organization after his visit to the epicenter of the Ebola outbreak in DRC. Although Dr. Tedros Adhanom Ghebreyesus struck a positive tone, the epidemic is being treated as a global health emergency. This is the Bundibugyo strain of the virus. It has a high fatality rate and there's no vaccine or proven treatment. The situation is worsened by the ongoing conflict in eastern DRC, where the military is fighting armed groups. Mistrust and misinformation also play a role. So how can medical teams overcome the challenges facing the response to this Ebola outbreak? We'll talk to our guests in a moment, but first, this report from Imogen Kimber.
The head of the World Health Organization says he's confident medical teams will stop the Ebola outbreak. It's just a matter of how quickly. Addressing media after visiting the epicentre in the Eastern Democratic Republic of Congo, Dr. Tedros Adhanom Ghebreyesus said the UN agency and its partners are making progress.
The outbreak had a big head start and we're still behind, but under the leadership of the government of DRC, we're catching up.
A week ago, there were around 1,000 suspected cases in the country. With testing, that number is down to just over 100. While DRC is experienced in responding to Ebola, this is its 17th outbreak. The east of the country, where the virus is spreading, lacks adequate medical supplies. That's partly because of conflict between armed groups. But the WHO says teams are working quickly.
Magic is happening, and if you see a treatment center being born out of really a derelict site, colleagues working together, not only to provide treatment, but to provide water, hygiene, sometimes even food.
Treatment units have been set up in towns and villages in 3 DRC provinces, Ituri, North Kivu and South Kivu, as well as in neighbouring Uganda. An agreement between the US and Kenya to establish a facility in central Kenya, however, is on hold after a High Court order. The isolation centre was planned to house Americans exposed to Ebola in DRC, while they were being monitored for symptoms. But Kenyans were furious.
They said this is an institution or it's a quarantine facility for only the Americans. So the Americans are selfish to the core. And we have to tell Americans to get off our noses business. Get off our Get off our skin.
There is no vaccine or specialised treatment for this strain of Ebola, so contact tracing is vital. And Tedros says to get ahead of the outbreak, health workers need to step up efforts to track possible infections. He also says blanket travel bans are not helpful, as they're disrupting crucial supply chains. Health workers also find they face suspicion and there is scepticism over the disease. The WHO's risk assessment for the outbreak remains unchanged. Very high at the national level, high at the regional level, and low globally. There is also some good news.
So far, 6 people have recovered in DRC and 2 in Uganda, showing that people can survive Ebola if they have access to care and go to health facilities as soon as they show symptoms.
Which means that despite the high fatality rate for this strain and the lack of vaccine, there is hope. Imogen Kimber, Al Jazeera for Inside Story.
Let's bring in our guest now for today's show. Joining us from Bunia in eastern DRC is Dr. Roseline Belizaire, the Emergency Director for World Health Organization Africa. In Kampala is Dr. Ekwaro Obuku, a medical physician who served as a policy advisor to Uganda's National Task Force during the 2022 Ebola outbreak. And in Nairobi is Dr. Gitinji Gitai, Global CEO of Amref Health Africa and Vice Chairman of the Coalition for Epidemic Preparedness Innovation. A warm welcome to you all. Thank you so much for joining us. Dr. Belizaire in Bunia, let me start with you. You are in Bunia, the epicenter of this outbreak. When WHO says the response is catching up, what does that mean in practical terms and what needs to happen to get ahead of the outbreak?
So thank you so much for having me. First of all, let me tell that as of yesterday, we have 363 confirmed cases in the outbreak with 62 deaths. So just to give you an idea that this outbreak is evolving very rapidly. So the response has been a scale up. WHO, together with the Ministry of Health and all partners, including Africa CDC and UN. So we have been reinforcing the capacity of our healthcare workers. First, in surveillance, so they have a more, I can say, material in order to conduct investigation at community level. We also scale up laboratory. Before, we are able to do only 80 tests a day. So far, we have a capacity of 800 tests a day. We also increase in number of beds that are available for treatment center.
Okay, so you've scaled up testing and there's an increase in treatment centers, you say, Dr. Belizaire. But when Dr. Tedros says that the virus had a big head start, the outbreak could have begun as early as January, what exactly was missed on the ground and who bears the responsibility for that delay?
So as the DG of WHO said, we have a delay in detecting this. And so far, I have been in the community and I was listening to the community what happened. And the story is very interesting because it's part of the culture. Someone died in Kampala and was brought back to the community in a coffin, in a casket that was, I can say, broken. And they decided to take that person and to put the dead body in a new casket, and they burn the broken casket. And 10 days after, all those who manipulate the body and those who, manipulate the casket, they start having the disease and start dying. So they believe that it was a witchcraft, that the casket came back to call them, to pick up them in the community. The other things also, I listen to the community, they confuse the symptoms with tuberculosis. When they see blood in the sputum, they thought it could be patients with tuberculosis who missed their treatment. So they were doing those kind of things. And they didn't believe it was it could be Ebola.
Right.
And also there is the fact that the symptoms are very similar to malaria. Malaria is endemic, and most of the deaths in children and also in adults are also being from malaria in that community. So they started having, auto-medication, going to pharmacies, going to traditional healers, and not thinking in going to the clinical. So
okay.
those who
Can I ask you, Dr. Belizaire,
this
is very important what you tell us here. Can I ask you then, in that case, how many communities remain out of reach because of the fear that you described, because of the mistrust, and how much then does that alter the official numbers that we have today, the numbers that you talked about in the beginning? Could they be much higher than what you have right now?
So far, we are making a lot of investigation in order to know how is really the real number. And we are also increasing community engagement so the community can have trust to report all the cases of the people with symptoms at the community level. Another also aspect regarding the delay is that the test, they conducted it in Bunia. But it became negative for Ebola Zaire because Ebola Zaire is the most common one, and this is what they did. So they have to wait to send the sample to Kinshasa before they know that. So far, we are really working with whole society, meeting with community leaders, meeting with youth, meeting with women leaders, with motor drivers, with people working in the mines, people also in internal displaced camp, because we have a 69 site of internal displaced population here in Bunia, and also 2 refugee camps. So we are really involving everyone in order to make them believe that the disease is true.
Okay. Thank you so much for really painting us a clear picture there of what's happening on the ground in the DRC and the sorts of efforts that you're undertaking there. If I can come to you next, Dr. Gitai in Nairobi, where is the real fault line in this outbreak, in your opinion?
Well, in my opinion, I think the biggest fault line is actually at the community level, the people themselves. If you listen to the story that is being told there by WHO, the people, and I just came over a call with Dr. Tedros, who was in Ituri, and he was explaining to me that the real challenge is humanitarian. It might be easier to manage the science, the public health, but if we don't handle the humanitarian crisis in Ituri, in Mugbwalo, then we'll not be able to handle the pandemic. The examples that are being given about superstition, the examples that are being given about people stopping barrier procedures from happening, the examples that are being given that people walk away from quarantine because they're hungry. People don't believe in what's going on. People believe Ebola is actually an external creation. Those have to be handled, and they have to be handled with a human-centered design right at the community level. For us to run ahead of the outbreak, the community must be our first point of intervention, funding, and activity before we can say we want to improve all the other things that we are doing which are necessary, early diagnostics at point of care and medical countermeasures that are being worked on.
Dr. Obuku, if I can come to you now in Kampala. Uganda, of course, has closed its border with the DRC, and you advised the National Task Force during the 2022 Ebola outbreak. Can you tell us what's different now than what you experienced in 2022? And what do you think the public outside of this region doesn't understand about the real pace of the current outbreak of Ebola?
Yeah, thank you very much for having me once again. The two outbreaks are different. The one of 2022 was from Uganda itself, in Mubende. It was a mining center there. And this one is different. It is imported. So compared to the 2022 outbreak of Ebola Sudan virus, that is, which was a high-intensity outbreak, compared to this one, which was imported from the DRC as the citizens of DRC chose to seek care in Uganda. So we've had just 15 cases in Uganda confirmed 2 days ago. The latest statistics are not yet out, compared to Mubende in 2022 September. When we look at the response of the community, we see that this one has happened in Kampala. It started in Kampala. Obviously, there is more access to information. There is easy access to information. The kind of population is more literate compared to Mubende. Because in Mubende, of course, we had the stigma, we had issues to do with safe and dignified burial, because we have our own traditional practices on how we would like to bury our dead in Africa. So those issues were prominent. In Mubende. It was a bigger epidemic, I think over 150 cases with over 55 deaths, including about, I think, 6 health workers. But in this case here, we are seeing a confined outbreak, which started in a private health facility, fewer cases among the known contacts, the primary contacts, and the health workers. So there is a distinction on what is going on today and previously. But
what about Dr. Obuku? What about, you talked about the distinction there between now and the 2022 outbreak. What about when it comes to regional coordination? What do you see as the weak points right now in regional coordination? It started, as you said, in the DRC, some cases in Uganda as well. What is the weakest point right now in trying to treat this outbreak regionally?
So if I got your question correctly, two things are happening. One, obviously, is the government is attempting to manage the communication because the communication has interrupted our trade. It has also interrupted our tourism. There is an international event being planned in the Rwenzori mountain, which is being affected. The bookings are being affected. We had to cancel our international pilgrimage here in Kampala because of the communication. Once we communicate even one case of Ebola as it is required in the international health regulations, it limits our commerce. And therefore, the government is trying to reposition itself on how to communicate. The second thing the government has done, of course, is to close the border They first started by stopping the flights from the DRC, but now closed the border, which is against the East African Community Common Protocol, where there's supposed to be a common market with common movements of goods and services and people. So that is what the government is doing. But so far, I think we are in control of the outbreak because 2 people have recovered. One died, the index case, and the others are under observation.
Okay, Dr. Belizaire, your thoughts about the regional coordination we're seeing right now. Is it working? Is it not working? And also, I guess, for our international viewers, important to find out more about the severity of the virus versus the distinction between the severity of the virus versus transmission. Can you explain it? Why does the distinction matter for how the public and governments handle the outbreak?
So, as you mentioned, we have a continental coordination together with WHO and Africa CDC and all partners. So far, this coordination has been putting in place in order to channel all the resources and avoid duplication and put a more mutualization and coming like in a coordinated way to support the member states. Uganda and DRC. And the severity of the disease rely on, so far I can say the case fatality rate that we are seeing in this outbreak is 17%. It's the case fatality means the number of people dying under the number of people who has been confirmed. So as you can see, is less, a case fatality rate is much less than the Ebola Zaire. But however, as you mentioned, we still need to know the extent of this outbreak. We still need to make more investigation, and we still need also to work more closely or closer with the community.
Okay.
One of my colleague mentioned that, all outbreaks start in community and end in the community. The community knows what we should do, but we need to have that trust that the community can really tell us how to adapt this response to their culture, because it's very contextualized. What we are doing in Kampala, we cannot do it in Ituri, because even though they have a lot of exchange, a lot of trade together, but the culture can be different.
Okay. Dr. Gitai, let me come to you now and ask you about Kenya in all of this. Kenya has no recorded cases so far of Ebola, and yet the Kenyan government is planning on setting up an Ebola quarantine facility in Nanyuki for American nationals who have contracted the virus. And this has created uproar in Kenya, with some doctors' unions saying that the government is compromising Kenya's biosecurity in exchange for foreign aid. If it's too dangerous for America, surely it's too dangerous for Kenya, isn't it?
I think this is a highly controversial case, and I think the issue here is about focusing on science and public health science that says, as we are saying, that the best place to respond to an outbreak like this is exactly nearest to where the outbreak is happening. So we would expect that the first intervention of increasing specialized care would actually be in DR Congo, where actually this is going on. But that doesn't stop us from actually building regional capacity. Then the question that comes in this particular conversation, because between you and I, none of us has actually the exact details of the bilateral agreement. We know that the US government has said this for Americans, the Kenya government has said this for everybody. So we do not have the actual details.
Well, President Ruto has said this is the right thing to do.
And the science says do it close.
President Ruto has said this is the right thing to do. In what way is it the right thing to do?
That is why I'm actually keeping away from the political statements that are saying the right thing to do is to build specialized response nearest to the outbreaks, that should be DR Congo, and also building connected regional capacity, not only for outbreak control, but also for specialized care for those who may be infected. But the most important thing is to ensure that we control the outbreak at source. Now, the agreement between Kenya and US is not public, so we do not know. The right thing to do is to build special capacity for everybody. We do not have two-tiered care. It is to build capacity for everybody everywhere without worrying about their nationality, their social status. It is to build capacity for response and for care for everybody. That's the right thing to do.
All right. As you know, doctors, one of the difficulties in getting on top of this outbreak is that there's no approved vaccine and no specialized treatment. 2 vaccines exist for the Zaire strain of the Ebola virus, which was responsible for the 2013 and 2016 outbreak in West Africa. The current epidemic is caused by the Bundibugyo strain. It has a fatality rate of up to 50%. Research and testing to develop a vaccine is underway, but it will likely be months before it's available. Dr. Belizaire, why is there still no vaccine for this particular strain, even though it's existed before?
So Ebola Bundibugyo has caused so far 2 outbreaks. That one is the 3rd one. The first one was in 2007, and the second one was in 2012. And now in 2026, we have the 3rd one. So the Ebola Zaire has been so far the most prevalent one and also the most the deadliest, Ebola species. So the priority for public health and for science was to have a vaccine for Ebola Zaire.
Right.
I think you
but
just
the Bundibugyo strain, I understand, Dr.
outbreak.
Belizaire, also raised alarm previously. Why is there still no licensed vaccine for that particular strain?
So to have a licensed vaccine, we need to have long outbreaks. As I mentioned, the Ebola in 2007 and 2012 were not very big enough because we need time in order to do the clinical trial in the outbreak. So when you see we have that Ebola vaccine for Zaire, the clinical trial started in Guinea and ended in DRC. So in DRC, we have to vaccinate more than 500,000 of people in order to have enough data and to say that the vaccine is effective. So with the Ebola Bundibugyo, we didn't have, maybe I can call it, opportunity to do it. And even now, if the vaccine is not ready, okay, in the next 4 to 6 months, if the outbreak ended before the vaccine is ready, we'll still don't have, because we need to have an outbreak with enough time in order to do the clinical trial.
All right, Dr. Obuku, your thoughts. Why do you think it's become so difficult still to develop and deploy vaccines and countermeasures fast enough for outbreaks like this one?
I think, and this is an important question because there have been 17 outbreaks in DRC. We should have learned a lot from them. And there have been 9 in Uganda. Obviously, we've got a vaccine for the Zaire, which has had the most outbreaks, but we do not have, it does not have cross-reactivity. Typically, you would expect that the one of Zaire would confer some level of vaccine efficacy or immunogenicity for the Sudan virus strain or the Bundibugyo strain, which is unfortunate. I think that African governments need not wait for the international community to invest in technology for vaccine discovery, especially for these rare but highly fatal outbreaks or diseases like viral hemorrhagic fever. I know that in Uganda, for instance, during COVID, due to the so-called vaccine apathy, limited access to the vaccines that were available for whatever reasons, okay? Whether it was supply chain chokes or just simply limited stock. The government of Uganda injected immediately $10 million into the COVID-19 vaccine research. But because of the nature of these viruses, they come and disappear very quickly, or they kill so fast to have a sizable number of people to test from. You find that we don't have sufficient time to actually develop the vaccine, such as the time COVID gave us. COVID vaccines were developed rapidly, but COVID gave us at least a year, in some places 2 years.
All right,
Here,
Dr. Gitai, let me get your thoughts.
4.5 months, we have controlled.
Yeah, let me get your thoughts about this. Is the absence of a vaccine, is it a scientific problem, a funding problem, or a lack of commercial interest in an outbreak that affects mostly poor communities on the African continent?
It's a market problem. And the market problem here is that, medical countermeasures are largely produced through commercial pathways. They're produced by private sector, of course, with the support of international community as public goods. We know that there's a lot of tax money that's poured into this, into research. I sit on the board of CEPI, and we have a lot of public money to develop, to work with others and the private sector and other innovators and academia to develop platforms for developing vaccines that may affect humanity now or in the future. Now, that funding assists development of research and development and the clinical trials, as was said earlier. And what happens is that the pathway to the market from to get the vaccine to the arm is a commercial issue. So when you see equitable access, it's a market-based challenge, because we always consider, and the people who produce the vaccines look at demand and supply. And the biggest challenge you have with Ebola, with all these pathogens that have been known for years, is that they don't have a market, unfortunately. They have a need, the people are there, but there's no commercial market.
Okay.
And there's not enough money being provided to provide the vaccines as a purely public good. So we need to unlock the market forces, we need to unlock equity so that actually we can provide the vaccines to the people who need them, because even when they're available in the lab, we hold them as stockpiles, but providing them at large scale will require commercial pathways. Now, Gavi, the Global Vaccine Alliance, has been used as an instrument to reduce the market gap so that everyone has access to them. But Gavi has to be funded by multinationals and other means for it to access these things. So it's a market force issue that we must resolve to ensure everyone everywhere has access equitably to these medical countermeasures.
Belizaire,
we must unlock.
We're coming to the end of the show, but please, Dr. Belizaire, briefly, if you can just tell us how we can be better prepared. How do we save lives for the next, outbreak without repeating these systemic failures?
I really love that question, because what we are seeing really is a lack of preparedness in the health system and strengthening capacity. Because now we are starting, prepare the system to be able to respond. How can we be better prepared? We need to have the financing of the national action plan for preparedness. So far in Africa, only 12% of the budget that we need to finance the National Action Plan for Public Health that has been mobilized. So that means those plans for preparedness are not really financed, and we need to put in place those activities.
Okay,
the international health regulation, they give us the pathway. They give us what we need in each area, in each pillar to put in place in order to be able. Okay. But so far, there is no domestic finance into preparedness.
Okay, we'll leave it there. Unfortunately, we're running out of time, Dr. Belizaire. Thank you so much. We're running out of time, unfortunately, for today's show. Thank you so much to all three of you for joining us on Inside Story, Dr. Roseline Belizaire, Dr. Ekwaro Obuku, and Dr. Gitinji Gitahi. And thank you, too, for watching. You can watch this program again anytime by visiting our website at aljazeera.com. For further discussion, go to our Facebook page. That's facebook.com/AJ Inside Story. And, of course, you can join the conversation on X. Our handle is at AJ Inside Story. From me, Folly, Thibault, and the whole team, thanks for watching. Al Jazeera's coverage continues in just a few minutes. Stay with us.